So, Dr. Greenspan, it's all yours.
Thank you. Thank you. Welcome, everyone. I'm pleased to be here. My presentation is on appropriate use criteria, standard of care, remnant ablation, and genomics and molecular considerations of I-131 therapy and thyroid cancer. I have one disclosure. Now, the definition of, we've talked about Theranostics. The definition of nuclear Theranostics is as follows. The term Theranostics is a portmanteau word. It's derived from the terms therapeutics and diagnostics. And nuclear Theranostics is the pairing of diagnostic biomarkers and therapeutic agents that share the same or similar molecular structure and identify the diagnostic agent and treat the therapeutic agent, the same molecular target. This commonality should improve patient selection, prediction of response and toxicity, prognosis, and ultimately improve outcomes. Now, regarding appropriate use criteria, these were published by the Society of Nuclear Medicine and Molecular Imaging in the Journal of Nuclear Medicine in 2020. And the requirement for these types of AUCs is that we get input from a number of various societies, so we get multiple viewpoints. Why AUCs and why now? Well, beginning on January 1st, 2023, this date has moved before. I don't expect it to move again. And in fact, down here it says 2022. It's 2023 now. CMS, the Center for Medicare and Medicaid Services, will require referring physicians to document consulting AUCs via an approved clinical decision support tool when ordering any nuclear medicine diagnostic imaging study. So there are various categories of various techniques that are considered either appropriate, maybe appropriate, or rarely appropriate. And appropriate ones here, I have listed initial staging for malignant iodine-avid thyroid tissue after thyroidectomy, assessing and quantifying residual iodine-avid remnant tissue, post-therapy I-131 localization, which is generally performed 2 to 10 days after radioiodine therapy, 3 to 5 days or 5 to 7 days are optimal, follow-up diagnostic restaging evaluation scan, and follow-up diagnostic restaging evaluation scan to determine if a structural lesion is iodine-avid. And one maybe appropriate technique I've listed here is follow-up diagnostic restaging scan with prior negative results of I-131 post-therapy images. Now, the diagnostic scan prior to I-131 therapy for thyroid cancer is commonly done with I-131 with a range of 1 to 5 millicuries. I think 1 to 2 millicuries is best to avoid the rare complication of stunning. If you don't use more than 2 millicuries, it's pretty unlikely to have stunning. Diagnostic scan using I-123 is also done, and the average of that is 275 microcuries. The post-therapy scan, which uses the therapeutic administration of iodine 131 for the scan, which means no additional administered activity is necessary. This scan is critically important for evaluation of disease status and determination of follow-up treatment, especially administered activity of I-131. And always remember, pregnancy and lactation are absolute contraindications to I-131 therapy. Post-diagnosis and post-surgery I-131 treatment is classified as follows. Remnant ablation, which is eliminate normal thyroid tissue, and the purpose is to facilitate follow-up by improving subsequent detection of residual or recurrent disease. Adjuvant treatment to irradiate suspected but unproven sites of malignancy. The purpose is to reduce risk of recurrence and prolong survival. And treatment of known disease, which is persistent or recurrent disease, local, regional, or metastatic disease. And the diagnostic scan, which may include SPECT-CT, may be helpful. Post-therapy scan is essential and critically important to assess presence and severity of metastatic disease and provides basis for subsequent I-131 therapy. I'm going to mention these again later. Now, here's a list from the publication that shows a list of 13 different scenarios and whether these scenarios are appropriate, may be appropriate, or rarely appropriate. And if you notice at the bottom, pregnant or lactating patients, rarely appropriate. It's almost never indicated to do that. Okay, so one possible risk-based strategy for radioactive iodine therapy for differentiated thyroid cancer is listed below. There's a lot of controversy here, and not everybody would agree with these numbers. So this is one set of recommendations. Remnant ablation could be arranged from 30 to 150 millicuries, which is 1.11 to 5.55 gigabecquerel. Adjuvant treatment, 100 to 150 millicurie, which is 3.7 to 5.55 gigabecquerel. Small volume local regional disease, 100 to 150 millicurie, 3.7 to 5.55 gigabecquerel. Advanced local regional disease or small volume distant metastases, 150 to 200 millicurie, 5.55 to 7.4 gigabecquerel. And treatment of extensive distant metastatic disease, potentially greater than 200 millicurie or greater than 7.4 gigabecquerel to maximum tolerated safe I-131 activity. Now this actually, I'm going to mention this later, but this actually is number one to keep the exposure to the bone marrow less than a certain level, and to keep the exposure to the lungs less than a certain level if there's diffuse lung disease. Now, factors determining prescribed therapeutic I-131 include treatment objectives, whether you're going for cure, progression-free survival, or palliation, the time interval since previous I-131 treatment, the amount of I-131 administered for the most recent treatment, response to the most recent treatment, total cumulative therapeutic activity of I-131, frequency and severity of side effects from previous I-131 treatments, and we need to take into account patient wishes and concerns, the capabilities of the treating facility, and regulations, whether they're federal, state, or local. Now, there is strong evidence over many years of clinical benefit from I-131 therapy. That's not in doubt. I-131 therapy has shown disease-specific survival and overall survival. Here are several references. There are many more. Now, we've mentioned the term differentiated thyroid cancer. This, by definition, includes papillary, follicular, and Hürthle cell cancers. And as you heard earlier, Hürthle cell cancers are now a complete separate category from follicular thyroid cancers. They used to be lumped together, but they're actually very different. And this term differentiated thyroid cancer does not include medullary or anaplastic thyroid cancer. Since there's so much controversy about the term differentiated thyroid cancer, I've been wondering whether we should call it functioning thyroid cancer. That doesn't quite answer the question either. Now, as far as the standard of care for differentiated thyroid cancer, first we need to make the diagnosis. That's generally done with discovering a nodule or whatever and doing a fine needle aspiration. Then next is subtotal or intertotal thyroidectomy, and postoperative management will include thyroglobulin measurement, neck ultrasound, and a diagnostic whole body scintigraphy with I-131 or I-123, which assists in characterizing tumor I-131 avidity and identifies extent of disease. Postoperative I-131 therapy, the goal is to determine largely by clinical and pathological findings, laboratory values, and information from imaging. Now, the overall term for I-131 therapy is therapy, but there are three types, which I've mentioned earlier: remnant ablation, adjuvant treatment, and treatment of known disease. Remnant ablation is a process of eliminating residual, generally postoperative, normal thyroid tissue. Rationale is that functioning tumor is less efficient than normal thyroid at organifying iodine and producing thyroid hormone. The goals are to reduce serum thyroglobulin to an undetectable level, which will facilitate follow-up and early detection of recurrence. It also enables high sensitivity post-therapy whole body scintigraphy for diagnosis and localization of residual tumor postoperatively. Adjuvant treatment, the goal is to treat suspected microscopic but unproven sites of metastasis based on histopathologic risk factors that predict tumor dissemination beyond the thyroid gland. The purpose is to reduce risk of recurrence and prolong survival. And I should mention there is commonly overlap of remnant ablation and adjuvant treatment. Treatment of known disease, which means persistent or recurrent disease, local, regional, or metastatic disease. The goal is treatment of regional or distant metastatic disease to eliminate iodine-avid regional disease or distant metastasis to achieve cure or remission, reduce recurrent or persistent disease, and improve overall prognosis and survival. By definition, remnant ablation is complete elimination or destruction of all normal thyroid tissue. And as I've mentioned, the purpose is that since normal thyroid is more efficient at uptake of iodine, removing normal tissue will facilitate detection of residual recurrent tumor. And remnant ablation with I-131 is considered a safe and effective method for eliminating residual normal thyroid tissue. There is a lot of evidence in favor of this. Remnant ablation is generally performed 4 to 6 weeks following subtotal or near total thyroidectomy. There is substantial controversy regarding how much administered activity for remnant ablation. Some physicians advocate 30 to 50 millicuries. Some nuclear medicine physicians use 100 to 150 millicuries. I generally use 100 to 150. And there's an interesting article by Castagna from Europe that looked at 30 versus 100 millicuries for post-surgical thyroid ablation. And their definition was low activity was 30 to 50 millicuries, high was 100 millicuries or greater. And their conclusion was in differentiated thyroid cancer patients at intermediate risk, high reactive iodine activities given for ablation have no major advantage over low activities. So you could conclude that 30 millicuries is equally as effective as 100 millicuries. You could also conclude that 30 millicuries is equally as ineffective as 100 millicuries. And as we heard earlier, the important consideration is not how many millicuries are given, but what the absorbed dose is. And the absorbed dose depends on administered activity, percent uptake, and remnant mass. The absorbed dose necessary to provide ablation is generally thought to be 300 Gray or 30,000 rad. The reference for this is Harry Maxson from the University of Cincinnati in the New England Journal of Medicine in 1983. And this is not a hard and fast number. I think we need further investigation to determine more precisely. But that's a general number that we can use. Now, we can obtain postoperative pre-therapy whole body diagnostic scans with I-131 or I-123 or even I-124 to identify and localize regional and distant metastatic disease and determine the reactive iodine avidity of these lesions. This information is used in planning subsequent I-131 treatment. Part of the reason why there's so much debate and controversy about diagnostic scans is that these scans frequently do not detect all lesions. So some people use them, I do, frankly, and some people think that they're not really useful and they don't use them. That issue is not settled yet. Management may be altered due to findings on the diagnostic whole body scan, and these findings may alter activity of administered I-131 or avoid unnecessary I-131 treatment. The use of SPECT-CT with the postoperative diagnostic scan may provide additional useful information, such as distinguishing thyroid remnant from nodal metastasis, detecting metastatic disease in normal-sized cervical lymph nodes, detecting pulmonary micrometastases or bone metastases, and provide information for dosimetry. Postoperative diagnostic scans may not detect all or any lesions, and enhancement may be a useful next step. Postoperative diagnostic scans may provide information that would indicate additional functional metabolic imaging, such as F.A.C.N.P, FDG, PET-CT, when non-avid radioactive iodine metastatic disease is suspected. Post-therapy whole body diagnostic scans with I-131 can be performed at 2 to 10 days post I-131 treatment. These numbers come from the AUC, from the Society of Nuclear Medicine Molecular Imaging. Optimal timing is probably 5 to 7 days post I-131 treatment. Now again, post-therapy scans are critically important for localization and evaluation of regional or distant metastases in planning for subsequent I-131 therapy. Now, there are two main approaches to I-131 therapy. One is a dosimetric approach, and this combines information obtained from the postoperative diagnostic scans in planning I-131 treatment, even though these diagnostic scans have reduced sensitivity compared to post I-131 therapy scans. Another approach that's also dosimetric is maximum tolerated activity, which generally is considered maximum exposure to the bone marrow. And there's also the risk-based approach, which utilizes clinical and pathologic factors and institutional protocols to determine I-131 treatment. Now, I've seen a statement in the literature which says currently no conclusive evidence as to which approach results in better outcomes was made. I think this comment is incorrect. And I think it's incorrect for several reasons. There's published data showing that use of dosimetry can minimize side effects to the bone marrow. Here are two publications. Published data demonstrating improved clinical response in metastatic disease using the dosimetric approach has been found Metastasis and dosimetric group were 70% less likely to progress. An advantage was specifically apparent in local regionally advanced group. This publication was by Klubo et al. In the Journal of Clinical Endocrinology and Metabolism in 2011. Now also, determination of minimal administrative activity to achieve desired therapeutic outcome, at least 8,000 rad to prevent progression of metastatic disease, and improve therapeutic response was based on lesional dosimetry. This also came from the article from Harry Maxon in 1983. However, this amount is probably not set in stone either yet. Early identification of regional or distant metastases may allow for successful I-131 treatment, which likely will improve outcomes. Postoperative whole body radioactive iodine scintigraphy predicts localization of therapeutic I-131 and is important for planning for I-131 therapy. I have mentioned this several times, but I think it's critically important. Now, there's the risk-based or risk-adapted approach. Administrative activity is chosen according to the goal of therapy and the estimated risk of persistent or recurrent malignancy, based on several factors, including local protocols, experience, and availability of patient-related parameters and imaging modalities. I listed previously the prescribed activities of I-131 treatment, and a risk-based approach with dosimetry can be used with patients who have homogeneous lung metastases, and you can do whole body dosimetry so that the prescribed administered activity of I-131 results in retention in the lungs of less than 80 millicuries or 3 gigabecquerel at 48 hours to avoid the complication of pulmonary fibrosis. This complication can be fatal and needs to be avoided. Now, whole body scans are generally done 1 to 2 years after the primary treatment. These are used to re-stratify risk of recurrence. Dynamic risk stratification is predictive of long-term clinical outcome. Patients with an excellent, that is complete response to I-131 treatment have a 1 to 4% chance of recurrence, which is a significant reduction to risk from the 36 to 43% risk in intermediate risk patients and from 68 to 70% in high risk patients. Distant metastases develop in approximately 10% of patients, and the prognosis is variable. In some patients, the disease is indolent. In some, it's very aggressive. Patients with radioactive iodine avid metastatic disease have a much better prognosis, greater than 90% 10-year survival, than patients with non-iodine avid metastases, which has only a 10% 10-year survival. The most common mutation of papillary thyroid cancer, as we heard earlier, is the BRAF mutation, the BRAF 600E. BRAF mutations degrade ability of malignant thyroid tissue to take up radioiodine. Follicular thyroid cancers more often have RAS mutations. These mutations degrade uptake of radioactive iodine by malignant thyroid cells less than BRAF mutations. Again, I've listed the definition of nuclear theranostics, the pairing of diagnostic biomarkers and therapeutic agents that share the same or similar molecular structure and identify and treat the same molecular target. So these two agents may not necessarily have the same radionuclide, but they will have the same structure and they address the same molecular target. And this commonality should improve patient selection, prediction of response and toxicity, prognosis, and ultimately improve outcomes. Now, Dr. Gulek has introduced these terms. Theranostics, which he mentioned, is a direct linking of diagnostic information to therapy. The theranostic value, which is the potential of a diagnostic tool to influence therapy. Theranostic power, which is the clinical strength of a theranostic tool determined by biological and technical factors. Theranostic technique, which is the contribution of technical factors in enhancement of theranostic power. And theranostic performance, which is modifications in theranostic power via modulation of biological and technical dynamics. So here's an example of enhancement of theranostic performance. This comes from Sloan Kettering in the publication by Alan Ho in the Journal of Nuclear Medicine in 2013. Steve Larson was also a collaborator. And on the left, you see a baseline scan using iodine 124 PET-CT. The whole body scan shows no active disease. On the axial image, you see a few lesions in the lungs. And after 6 weeks of therapy with selumetinib, there is a significant increase in the number of iodine-avid lesions, and now that this patient can be treated with radioactive iodine, with much better results. So we can enhance the theranostic performance of radioactive iodine. Oncobiology of thyroid cancer decreases theranostic power of radioactive iodine. Selumetinib is one agent that can enhance iodine incorporation in patients with I-131 refractory thyroid cancer and reverses I-131 resistance. Selumetinib effects upon iodine incorporation may be dependent on clinical factors and/or tumor genotype. Now, it turns out there are several of these kinds of agents. Selumetinib and trametinib are MEK inhibitors. Dabrafenib and vemurafenib are BRAF inhibitors. Now, there's also the thyroid differentiation score, or TDS. TDS is a quantitative molecular measure of functional differentiation or de-differentiation of thyroid cancers. TDS influences theranostic power of radioactive iodine, and thyroid cancers with low TDS are radioactive iodine indifferent. So in conclusion, to improve outcomes, we need to understand the uses of nuclear theranostics, including theranostic value, theranostic power, theranostic technique, and theranostic performance, the use of the thyroid differentiation score, incorporation of information from genomics, and the use of lesional dosimetry will become critically important in the near future, and the theranostic performance can and should be enhanced. And further conclusions, remnant ablation with I-131 is considered a safe and effective method for eliminating residual normal thyroid tissue, since it facilitates follow-up by improving subsequent detection of residual or recurrent disease. And post-therapy scans are critically important for localization and evaluation of regional or distant metastases and planning for subsequent I-131 therapy. Now, I believe that the recent article in New England Journal of Medicine was mentioned earlier, and I'm sure we'll have some discussion of that discusses that remnant ablation is not necessary. Now, this article only addresses low-risk patients, but I think it's been already misunderstood. Anyway, with that, thank you very much.